talking about the different types of leukemia. I will start next week. Probably only to get through the first PowerPoint. Next week, I'll take a look at it and see. We'll see where we get. At most, we'll get through 2. I won't take you through any more than 2. It is too much information to ask you to even partially be responsible for, to go through more than 2 of them. Okay. We classify leukemias. There's 2 different classification systems. There's an older one and a newer one. But Jean has been to several meetings and we've discussed this multiple times about dropping the older one. Well, the problem is they still refer to this out there a lot, so the general consensus amongst educators in the MLT level is that they still teach both. I'm going to go over both of them. The one you really should concentrate most on is the one from WHO, okay? WHO, the World Health Organization. The FAB classification, this was developed back in the 70s, so back before we had CD markers, flow cytometry. There was some rudimentary cytogenetics at the time. They could find a couple of very glaring abnormalities that were out there, but for the most part, we relied almost exclusively on morphology and what we call cytochemistry. You can all be very grateful we don't teach cytochemistry anymore because it is awful. We finally did get rid of that a couple of years ago, mostly because nobody in the country does it anymore. Literally, we had a physician who wanted it done. She insisted that that's what she wanted done with her bone marrows. We could not find any place in the country that would do it. There's one place in Seattle that still did them, and they didn't take specimens from outside labs. So, we stopped teaching it. Some of the markers still come up, myeloperoxidase and TDT. We still use those a little bit. The myeloperoxidase, they actually use them as Sysmex analyzers. And TDT is a CD surface marker. Okay, so it has been reclassified. So we replaced these specific stains with cytometry and CD and with flow cytometry for CD surface markers and with cytogenetics. It was revised in 85 and I believe again in 88. When they split it up, and these are classifications of acute leukemia. Okay, so FAB is for acute leukemias. They named them very, very ingeniously L1, L2, and L3. Somebody had to think long and hard about that. Okay. Most acute lymphocytic leukemias are this L1. There's a few, about a third, are L2. This Burkitt's is quite rare. And the only thing I really need you to remember from this slide, and this will come up in the WHO classifications as well, is that L1 and L2 are TDT positive. L3 is TDT negative. That's a question we've seen come up on the boards more than one time. Okay? That your acute lymphoblastic leukemias, L3 is your TDT negative. The other 2 are TDT positive. When we get into the myeloids, again, somebody really working overtime deciding how to name these, M0, 1, 2, 3, 4, 5, 6, 7. They started with 1 to 7 and then decided they had to add M0 because we had one that was left differentiated. These top 3, M0, M1, and M2, are all myeloblastic leukemia. This gets a little confusing because we have minimally differentiated without maturation and with maturation. This does not mean that I have later stages, this just means that my blasts are more mature. Truthfully, this M0 And again, these are not like poof, one stage to the next. They can sort of transition between these three. This M0 is almost stem cell. Okay, it's an almost stem cell leukemia. They're minimally differentiated. A lot of time in M0, they don't even have blast markers on them yet. Okay, so that means that they are very, very, very young blasts. In 2 and 3, or in M1 and M2, we start to see some maturation of the blasts. Okay, and that's what I have to point out here, is that when we're talking about this with and without maturation, we're talking about the blasts themselves maturing, not necessarily mature forms of the leukocyte. So we're not going to see metas, myelos, and pros. We're just going to see older blasts. Does that make sense? Okay. Acute promyelocytic leukemia. This one is particularly important, and it is the only one in the WHO system that has its own little world. It has its own classification in the WHO system. All of the rest of these fall under acute myelocytic leukemia. And does anybody know what NOS stands for? What's NOS stand for? You're going to see it a lot in the medical fields. NOS stands for not otherwise specified. Not otherwise specified. So in other words, we're going to the only one of these classifications that has its own WHO classification is this acute promyelocytic. And we will talk about that when we get to it. The rest of them, they all fall under basically NOS is a way of saying other. Okay, so this entire classification system now falls under the other category. So what used to be the entire world of leukemias is now, this would be a teeny tiny like footnote. Okay. The WHO classification of neoplasms, we differentiate based on morphology, but also genetic testing and flow cytometry, especially genetic testing. The last reclassification of the WHO, I actually went to a 2-day workshop on it because it was so confusing and there was so much to it. I don't learn as well from reading. I learn much better from listening. So I actually went to some lectures on it. Besides, it was a trip to California. That's where I took my vacation that year. So I went out and he talked about it and he really made it make sense to me. What they did, most of it is actually on this genetic testing, because we are able to sequence genes so much more rapidly and so much more accurately than we used to. They're finding a lot of genetic similarities, and so they're starting really to divide these leukemias up, less by what it looks like and more by what its heritage is, what gene is coming from. The first thing, we're going to split it up in 2 ways. The first thing we're going to do, we're going to split it by what kind of cells we're looking at. The cell of origin, we're going to look at myeloid cells and lymphoid cells, then the histiocytes and dendritic cells. This is all we're going to talk about, histiocytes and dendritic cells. That's it. It exists. There you go. The only test question I might ask is, what are the 3 categories? That's it. Okay. The myeloid and the lymphoid we're going to talk about until you're sick of them. Lymphoid are lymphocytes and myeloid is everything else. Okay. This is what comes from CFUL, and this is what comes from what?
Gem.
GEM. G-E-M-M. You'll know that by the end of the semester, promise. Then after we differentiate them based on their cell line, then we differentiate them based on how much differentiation of the cells themselves we have. You either have a what they call precursor, which is acute, yes.
So you said the myeloids come from gem and
The myeloids are from CFU gem and the lymphoids are from CFUL. call them acute and chronic in FAB, and we still call them acute and chronic in the lab when we're actually talking about them. Precursor and mature. So in the precursor ones, does anybody remember how many blasts have to be present to make it an acute leukemia? Greater than 20% per WHO, okay? FAB says 30, but WHO says 20. So that's gonna call it an acute or a precursor leukemia. And then we have a mature or a chronic. And again, we'll get into those significantly. But when we're differentiating based on who, we differentiate by cell type and then by stage. When we're doing it in FAB, it's kind of the other way around. We do by immature or mature, and then by what cell type. Acute neoplasms, 20%, greater than 20% blast in blood or bone marrow. FAB classification says just bone marrow. The blast cutoff, however, may not apply if we have a recurrent genetic abnormality. In other words, especially if you've got someone who had leukemia before, if they come back with a genetically positive cell, even if they're not at 20% blast, they're still going to classify it as an acute leukemia. Okay? So we really are starting to rely more and more on these genetic abnormalities to tell us what kind of leukemia we have. Okay? We may be able to treat it before it gets to the overwhelming blast. The precursor lymphoid leukemias we then split down further into the B cell and the T cells. Leukemia and lymphoma have kind of been, they used to be really separated out. They've kind of mixed them together again because for the most part, leukemias arise in the bone marrow and lymphomas arise outside the bone marrow, but they're pretty much the same thing. You used to have CLL and SLL, small cell lymphocytic lymphoma, and chronic lymphocytic leukemia. They're the same basic disease, it's just where the lymphocytes are running amok. Are they arising within the lymphoid tissue or a solid mass somewhere in the body, or are the lymphocytes being overproduced in the bone marrow itself? But as far as treatment and as far as classification and everything else, pretty much the same disease state. We have AML with recurrent genetic, we have AML with myelodysplastic, and don't worry, we're going to go through all of these. Therapy-related neoplasms of myeloid precursors. In other words, if we give you chemo for some other kind of cancer, sometimes it induces cancer of the bone marrow. Sometimes you get a secondary leukemia. Stinks. Sucks to be you. And then you have the other classification, and that's the old FAB. Chronic or mature neoplasm involve a proliferation of all stages of cells. Okay, so we're not only going to see just blasts, we're also going to see more immature cells. We're going to see metas, myelos. Somebody who loves me very much and found that torturing students sounds like a lot of fun gave me a lovely CML slide about a month ago. 300,000 white count. Believe me, counting it won't take you long. 100 cells, like maybe 2 fields. Okay. And all of you will count a CML slide before you leave here. All of you will count a CLL slide. You'll like that one. Lymph, 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 ding, lymph, 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 ding. Pretty straightforward. Simple to count. Okay. But I want it ingrained in your brain. Yes.
Do we have cell counters here?
Yes, we do. Not the fancy ones. We got the old clunky ones. But that's one of the things we're going to do today is find cell counters at work and try and get set up for doing gifts. We have the myeloid neoplasms with eosinophilia and TK mutations, then the myelodysplastic myeloproliferative neoplasms. Again, we're going to go through all of these. We'll separate them out. For right now, just know the overall categories and how we differentiate them. Oh my. That's just the B cell, plasma cell neoplasms. Like I said, these the nice thing, you'll be glad to know, we really only look at a couple of these, and I really narrow it down for you. So, the lymphomas, the T cell or NK. NK is natural killer cells. There are 3 categories of lymphocytes: T cells, B cells, and natural killer cells. Okay. And so we're going to be talking about, these are your lymphomas. Okay, these are your lymphocytic leukemias. The treatment of leukocyte neoplasms. Jean was very sad when I read this lecture, but the thing is, this is a dynamic field. Okay, I can't change the lecture fast enough to keep up with what's going on in the field. I really cannot. Okay. So I'm just going to give you an overall categories of how we treat things. There are newer and newer and newer drugs. Not only newer drugs, but newer methods of drug delivery. They're actually, we have some antibody-guided type cells. Okay, CD34 is on a blast, right? So what would happen if I put the medicine and attached it to an antibody to CD34? The only thing it's going to hook up to are those blasts. So I can direct it, biologically direct it at that particular cell. And there's other delivery methods besides antibodies. They are now working to try and do the same thing with a molecular piece, with the molecular tag. Well, we know that the BCR-ABL translocation is what causes our CML, so could I maybe attach the medication, the poison, the killer stuff, could I maybe attach that to some sort of genetic tag that will only go in and attack cells that have that genetic piece? Now, it sounds real simple, but it's not quite that easy. So they are absolutely redoing this by leaps and by bounds. Just one case in point, very, very near and dear to home. One of the guys we worked with about, I guess, 8 years ago now. God forbid I ever be in this situation. How would you like to run a CBC on your friend's son and know before he did your kid had leukemia? That your friend was going to be pulled into a room and told your son has leukemia. That happened to one of the guys that I worked with. He and Brian were just very good friends, and he ran Brian's son's, he came in for a cough. They ran it, he had a 50% blast. He had a 60,000 white count. They told him, okay, it was ALL, which if your kid has to get leukemia, which I pray no one ever does, but if that is what happens, that's the one you want, because there's about a 90% cure rate on that one. Until it turns out that he had a genetic abnormality in the cells, and we'll talk more about that later, which took his chances overnight from 90% to 20% survival. They put him in a pilot study. They gave him choices. We can treat it the way we've always treated it. We got a 20% chance that it will work. We have a pilot study. We've only had 20 kids, but every one of them has survived. Okay, you make that choice as a parent. How many of you are parents? Okay, make that choice for your kid. Can you imagine? It turns out he put him in the pilot study, and now that is the way they treat all patients with this, and recovery rates on these are 75% at this point. They treated it based on the genetic abnormality instead of based on the morphology. And he is now an annoying teenager. Okay. But it changed literally within the 6 months that they were treating James. And he was in the pilot program, which is now how they treat all of them. He got lucky, he really did, because the pilot program was here at a hospital in St. Louis. Okay. So it changed in a course of 6 months. Imagine what it changes in a year. You cannot keep up. There are now the newest treatments for Hodgkin's lymphoma. I read something that said newest treatments for Hodgkin's lymphoma. I got the article bookmarked, and when I have time, I'll read it. But they are changing very, very rapidly. They still fall into some basic categories. The first is radiation. Radiation is used as kind of a laser. It's targeted for localized malignancies, solid type tumors. The problem with some of, especially the lymphomas, they like to go other places. You'll find them as brain tumors, you'll find them as lung tumors. And sometimes, especially with the brain tumors, they'll use radiation to try and kill off just that little area. They're getting better and better. It used to be, well, we're just gonna put you in there and fling some radiation at you, see what happens. Then they targeted it more and more. Well, now they actually can make some sort of shield that they put like around the area so that you're only targeting that area and the radiation doesn't get anywhere, other places. Chemotherapy. Chemotherapy is just a fancy term for drugs. Various agents are used for different neoplasms. They change all the time. Some are more effective than others. Sometimes it's a matter of finding the right cocktail. We'll try this one. No, that one's not working. Let's try this one. So kind of mix. They come from a variety of places. Some of them are neurotoxic. There's one that they use that's the same thing that's the active ingredient in a pesticide. It literally is a pesticide. It's a neurotoxin. But that's what kills the cells. So that's what they use. Targeted therapeutic agents, that's what I was talking about with either biologically targeted or genetically targeted, that they're trying to find ways to deliver the chemotherapy and deliver the treatment, and not just for leukemias, but cancers overall. They're trying to find ways to deliver it so that it goes in, it's kind of, instead of sending in the army to just kind of wipe out the whole area, they're trying to send in special forces to sneak in and just kind of blow up the bad ones. Okay, try and minimize damage to the surrounding area. Bone marrow transplant is still very, very active and still one of the most common ways to treat leukemias, because most of this is arising in the bone marrow. There's two different types of transplants. One is a full marrow transplant, and in the last decade or so, we've actually been able to start pulling stem cells. We can actually hook you up to a pheresis machine, and I don't know how they do it, don't ask, I haven't had time to research it. It's on my list. Thinking we take a vacation for a month and just do nothing but research, read all the articles I have bookmarked. But they can pull the stem cells out and save just the stem cells, and then what they can do is they can transplant the stem cells in. Okay. It's a lot nicer for bone marrow donors, because if you're donating marrow, they actually have that bone marrow procedure we talked about. They actually have to go in and do that from about 30 to 40 different sites in your body to pull the marrow out. They put you under for that one. And then they hang it like a bag of blood. They literally, it just looks like a unit of blood hanging, and it drips in, and the cells naturally just migrate to where they need to go. The stem cells, though, it's a lot less invasive for the person donating, and as a matter of fact, they can actually, if they can get your condition in remission, they can pull those stem cells out and give you your own back, which gives us protection against some other things that can happen. Okay. An HSC, which is what they call that's the stem cell. HSC is a hematopoietic stem cell transplant. It's preferred over the traditional marrow transplant. Okay. If all I need are just the hematopoietic stem cells, why would I give you all of the other stuff that's in your bone marrow? Okay. We're looking at allogenic means that somebody else. We got the stem cells from somebody else. We have to find an HLA matched donor. HLA are human lymphocytic antigens. These are on the outside of all of your cells. Okay? So Every cell in your body has a little sign. It says, hello, I'm Diane. Okay. It says, hello, I'm Chris. Okay. And my immune system goes around through my body, and if it doesn't see the little sign that says, hello, I'm Diane, it kills it. So we have to find something that's close enough that my immune system's not going to attack it. But you're not going to find an exact match except maybe on your identical twin. Yes.
So why is it that not all family members could be donor? Is it a blood typing?
Because
as well?
it's not blood typing, and as a matter of fact, you can actually, we've had 2 patients that I know of who had a bone marrow transplant and their blood type changed. You want to talk about free guy blood banker. I had this lady typed 3 or 4 times, and finally Dr. Visconti called in and he goes, you all do know she had a bone marrow transplant, right? No, thank you. Nice to know. So when you hear about them, well, we've got to find a match. Well, did any of you watch Hawaii Five-0? Okay, stupid dorky show. I like it. Anyway, I know I'm the same blood type, so you can use mine to do the transplant. That ain't how it works, boys and girls. It ain't your blood type. As a matter of fact, that's like the last thing. There's something like 400 antigens that they check to try and match you up. So when they talk about cross-matching or getting a compatible, in this case stem cells, but it would be the same for a liver or a kidney or anything else, they're checking these HLA antigens. That's what they're looking at, not your blood type. The problem is you've got to find one that matches well enough. And we have to be very careful, especially with our stem cells, because we're transporting in lymphocytes, aren't we? Okay. Graft versus host disease is when you transfuse someone or transplant in an organ, okay? Host versus graft is what we refer to as rejection. Your body goes and says, that's not me, and it destroys it. In graft versus host, and this is really bad in our hematopoietic stem cell transplants, what happens is you transplant in the lymphocytes, and suddenly the lymphocytes look up and they go, ah, where am I? None of this is me. And they clone and attack everything foreign. So the thing that you transplanted in attacks the host and destroys any tissues from the host. Needless to say, this is a horrible, horrible way to die. So you have to be very careful when you're finding these HLA matches. Now they give you immunosuppressive drugs and all kinds of other things. A lot of times we irradiate to kill off the lymphocytes. Yes?
So that's the reason for like organ rejection?
Yes, it's exactly the reason for organ rejection. Organ rejection is host versus graft.
And then, so, because I had a lot of patients who had like organ rejections.
Mm-hmm.
So, they do that in HLA match donor. Is it kind of like a hard thing to do?
Yeah, there's no one else on earth who is going to be your exact match. It's going to be, like I said, except for an identical twin. And even then, sometimes you get little glitches. But you've got to remember, okay, your sibling, you've got for these 400 and some antigens, each one you get one from mom and one from dad. So that's 800 right there, possible combinations. So then look at the permutations on that, and it gets into the millions. The closer your familial relationship, the more chance you're going to have. That's why siblings are often the best chance. That's why parents are rarely the best match, because only half of what a parent has is what the kid's going to have. So that's why siblings are often a better match. And sometimes it still doesn't work.
That's horrible.
What's that?
That's horrible.
It is horrible. Unfortunately, we deal with some very horrible things, and I say all the time, it's like, oh, look at this light, oh, this is cool, oh, wow, oh, look at these, oh, this guy's gonna die for sure. You know, it's not that we don't care about our patients, we do care about our patients. But what's really interesting for us is usually not really good for the patient. It's usually bad news if we find something really, really interesting. Oh, look at this parasite, ooh, you know, oops. An autologous bone marrow transplant or hematopoietic stem cell transplant is where they save your own stem cells and give them back to you. Okay? The procedure, and this is, believe me, this is like nothing. What we're going to do is we're going to wipe out your bone marrow. That's the first thing we have to do. If we try to just transplant in new marrow or transplant in stem cells, you're just going to have a battle. Your bone marrow is going to have a battle for who gets to stay and who's going to go. Okay? This is not the way. Basically, nobody wins. Mutually assured destruction. Okay, that's right. You're not children in the 80s now. So we want to suppress the marrow. We want to try and basically wipe it out. These people will come in with a white count, whatever it is, and within days we'll be down to a white count of like 0.1. Okay, that's normal. That's what we want to see. We want to see no cells. We want to see those being destroyed. We want to wipe out what they have. Then you can either, number one, wipe out all the bad stuff, and then we just kind of we stop treating it and just kind of let everything repopulate. That's the most common. That's what we like it when that works. Okay. If we don't do that, then what we do is we transplant in the marrow or the stem cells to repopulate the marrow before we let it start to sort of, get back to normal. We check for engraftment. That just means that we make sure that the marrow we gave them is actually in their bone marrow and actually reproducing and actually growing. And then we just monitor them routinely for the return of abnormal cells. James has to go in every 6 months religiously for a blood test for BCR-ABL. And as long as he stays negative, I think he's only got 2 more years to go before they'll call him cured.
How many years is it?
What's that?
How many years is it used?
10. It's almost 10.
They can relapse after that long.
They can relapse it. He could relapse into CML when he's an adult. He has much higher risk of other cancers later when he's an adult. But he survived this one. Now, I don't know if he's going to survive his teenage years, but I think his dad's about ready to kill him. But that's pretty difficult. All right. Couple of things I want to go over before next week's test. Quantitative and qualitative disease states is going to be on the next test also. It was on the last test. We're going to pop it back into this one. The main reason I threw out, before I gave you the 7 points, I actually threw out a couple of the multiple choice questions because almost nobody got them right. Okay, so I want to revisit that one, so that one is going to be back on for the next test. When it comes to the case studies, the second one, does anyone remember what the second case study? We had an old lady came in, Granny Smith came in, and she had a cough and fever, elevated white count, definite left shift. She had 86% neutrophils and 6% bands, so she had a left shift going on. What's the most likely reason for it? A bacterial infection. Okay, somebody who said bacterial infection, I'll pick on you. Why is it a bacterial infection? How do you know that? What were your clues?
Elevated white count and, what was the elevated, no, I don't remember.
The neutrophils were elevated. Okay, and what do neutrophils fight?
Bacteria.
Bacteria. Somebody said viral infection. Well, you got the infection part right. Please don't believe me, I have worse answers than that. So bacterial. So this is where we're trying to put it all together. The good news is on that particular thing, 20-some points of that were just knowing high and low. Did I not warn you to learn your normal ranges? 20 to 30 points, sometimes even more on each test are just going to be high, low, normal. That's all you've got to do to get those points. I have a column there for you to write high, low, and normal in. Please, everyone, that's where I want you to write high, low, and normal. It makes it a lot faster for me to grade. Okay, I'm more forgiving. I put 6% bands on this one. Those of you who said it was normal because 0 to 5 is normal, I gave it to you. Okay, if it's right on the borderline, I'm not going to be that ungodly picky about it. Okay, but I want you. Okay, so we talked about we had the bacterial infection. What would I see if I had a viral infection? I'd see an elevated lymphocyte, and somebody else answer up. What specific types of lymphocytes might I see?
You can see reactive lymphocytes.
Reactive lymphocytes or atypical lymphocytes might be something that I would see in that. And in viral infections, believe it or not, all right, in mono your white count goes up, but in many viral infections, your total white count actually goes down. We see a lot of times people who have the flu, they'll have a white count under 3,000. I don't know why, and I don't find it in the textbooks, but having worked in the field for over 25 years, it's something you see all the time. Yeah.
Could you use the fever too as like something to like pinpoint your
Right, a
answer?
fever, yeah, a fever usually is speaking to the fact that it is an infection. So yeah, that would be a clue. The biggest piece is read the patient history. Okay, that first one, if you didn't read the patient history, it wouldn't make any sense to you at all. But the guy comes in from a car accident with a low H&H, well, I wonder where the blood's going. Okay, you know, you're gonna walk into his room and it's basically gonna be all over the floor. Okay, so read it because there's almost always clues. Almost, there's not always, but almost always clues in that patient history. Okay, to help you put it all together. But those case studies, it's like 5 points to answer the questions, but it's like 20 points to mark them high and low. Guys, those are like gimme points. I am like handing them to you on a silver platter. Okay, so learn your normal ranges for everything. Right now, CDC and diff. As we start doing more procedures, we will add those other normal ranges in as we start doing those procedures. But right now, know your normal ranges for the CDC and the diff. Okay? That's one place I can tell you right now, many of you could pick up a good 10 points for very minimal work. And you don't, if you don't remember the exact 4.4 or 4.5, at least get close. Round if you have to. Because usually when I put them on there, I try to put them on there, so if it's not normal, it's really not normal. Okay. Sometimes I'll hit borderline, but like I said, if it's borderline, if it's only out by 1 or 2, a lot of times I'll give it to you if you give me either way. Okay. Be able to recognize, especially an elevated white count. Several of you missed that the white counts were high on those things. Okay, so please make sure you're really looking at that. That's someplace I would say spend some time on. If you didn't do it last week, do it this week. Okay. I'm going to put some more A and C problems on there. Okay, because that one was almost universally missed. A couple of you missed the RBC and MCV problems. Those were reviewed from MLT 150. If you don't understand them or you're confused, please come see me individually and I will be happy to set up a time that we can discuss them, go over them. They will come up later when we're talking about anemias, so we will be seeing them again. They will not be on the next test. okay? They will not be on the next test. But that does not mean you can ignore them and let them go away. You need to pay attention to those. If you did not get them correct and you do want to speak with me, please just shoot me an email or, come talk to me and we'll set up a time. Nobody else has to know. I'm more than happy to. I'm really good at secrets. I am great at secrets. What's that?
You work with HIPAA too long.
It's not HIPAA. Everybody knows that. Yeah. They were telling me, oh, we're gonna have all the scheduling problems. We're gonna have every train. It's great. And I'm sitting there thinking, and Nicole's leaving in 2 weeks. And sure enough, 2 weeks later, she gave her 2 weeks notice. Somebody said, did you hear Nicole? Oh yeah, you did. I know a lot of stuff. I have so many secrets I've forgotten. Well, that's the other thing. I'm forgetful. So you tell me something. Oh yeah, you can say something. A and C's. How do I calculate an A and C? Bands plus segs is going to give me my relative percentage. Okay. And I'm going to take that, convert it to a decimal, and multiply it by my white count. That's how I calculate my A and C. How do I tell the difference between a relative neutrophilia and an absolute neutrophilia? Absolute, my ANC is greater than 8. How do I tell if I have a relative neutrophilia? If, right, it's not, well, actually the other way around. If your percentage of neutrophils is high, if your percentage of neutrophils is normal, it's not relative increase, okay? But if my neutrophil percent is high, then I have a relative neutrophilia. Would it be helpful if I put up a worksheet with the answers? Would it be helpful if I put, okay, what I'll do, last year I had it on a test, I'll just copy the test questions and put them up. But, yeah.
And is there a way that you can like go over probably, like 2 or 3, or I can just come and right?
We can do that, that's fine. If you want to go over some, I'll be happy to. Some of you are well ahead in lab. Actually, most of you are at least caught up, if not ahead, and we do have an open lab day pretty much next Thursday. So if you want to spend some time in lab, I'll be glad to go over some of them, but I will put up a worksheet for practice, and I will put up the answers and explanations on it. Yes?
When you say it's an open lab day, until what time?
Next Thursday? What is the date next Thursday?
23rd?
The 23rd. That's Riley Day. My granddaughter's coming over to play after she wakes up from her nap. So I will probably be here till about 2.
An hour before.
Yeah, I will probably be here till about 2. But the whole time, like pretty much from 9 to noon, is going to be just for whatever people need to catch up on. I try to put 2 open lab days in there, one at the end of the wet work, and then one later on for diffs. But you guys are doing really, most classes are either better in lecture or better in lab. You guys seem to be a more lab. You're doing a little better in lab. It doesn't matter. You're going to be just fine, but it's just each class is a little different, and I have to adjust for that. So the A and C, let's do one problem together. Somebody get a calculator, because Lord knows I cannot do math in my head, especially not this morning. I want to do at least 2 problems, so let's go with a white count of 15. Okay. My neutrophils and that'll be my segs plus my bands, okay? Let's say that my neutrophil percentage is 71, okay? I want everyone to calculate the ANC. Just keep it to yourself for a moment. Someday. So we'll go over a couple here in class. Then I'll put up a worksheet for you, and then I'm going to put several of them on the next test.
So you said the neutral is both bands and seg bands together?
Right, you're going to add your bands and segs. And truthfully, you're going to add in your immature grands as well, but we don't have to yet. So it's your bands and your segs. Does everyone have it calculated? Someone want to give me a number? Or do we need to discuss how to calculate it?
Well, it's still part of that.
Okay, my white count is 15. My neutrophils are 71%. Convert 71% to a decimal and I get what?
0.7.
0.71. So somebody put that in a calculator, right? What is it? 10.65. 10.7. And the unit on the ANC is an actual, this is a number. This is a how many per millimeter cubed you have, times 10 to the third per millimeter cubed. Everyone with me so far? We convert our neutrophil percent to a decimal. By mathematical definition, you move the decimal point 2 places to the left, okay? And then I multiply it by my white count. And that gives me a number. What's the normal range for neutrophils? That way you don't have to remember, okay? Normal range is 40 to 80%. Everyone with me so far? So we've calculated our ANC. So now I want to know, is this a relative neutrophilia, an absolute neutrophilia, both, or neither? And those are going to be your options on the test. I just copy paste that 1 to 1, okay? It's going to say exactly the same thing. So it's either relative, absolute, both, or neither, okay? So let's look, is it a relative neutrophilia?
No.
Why not?
It's within range.
It's in our normal range. So it is not a relative neutrophilia because our percent is normal. That's how you tell relative. If the percent is in the normal range, it is not a relative neutrophilia. If it's high, it is. That's all there is to it, okay? You evaluate that independently. Then my ANC, is it an absolute neutrophilia? Why?
It's high.
Because it's greater than 8. So in this case, it is an absolute only. Okay? Let's do another one. Because there's going to be a lot of points on the test. Let's say I have a 5,000 white count and a 92% neutrophil. What's my ANC going to be? I'm going to take 5 times 0.92, because that's my percentage, right, converted to a decimal, and I get, what was it? 4.6. Okay? Now we're going to go back and we're going to evaluate them individually. Do I have a relative neutrophilia? Yes. Why?
Neutrophils high.
Because my percentage is high. Has nothing to do with anything else. My percentage is high. I have a relative neutrophilia. Okay? Do I have an absolute neutrophilia? Why not?
Because it's not greater than the absolute value.
What is not greater than?
The 5.0 the 4.6.
The 4.6. My A and C is not greater than 8. If my A and C is not greater than 8, I do not have an absolute.
So you said it was relative, no, it was a neutrophilia, right?
This is a relative only.
Okay.
This is relative only. Okay. We're going to do one of each of the other ones, just that way you can see one of each. Then I will still put up a worksheet for you. Okay. Let's say I have a white count of 40 and a neutrophil percent of 42. Nope, hang on, that's not gonna do what I want it to do. That's not gonna do what I want it to do, hold on. Let's make a white count of 10 and a neutrophil percent of 74. That'll do what I want it to do. 74%. And a white count of 10. I can multiply that one and make it, that's why. Everyone understand where that came from? I take my neutrophil percent, convert it to a decimal, multiply it by my white count. Do I have a relative neutrophilia?
No.
No. Because?
It's within range.
Because my neutrophil percent is within the normal range. Do I have an absolute neutrophilia?
No.
No.
It's below
Why
8.
not?
It's below 8.
My A and C is less than 8. So in this case, I have neither. Okay? In this case, I have neither. I have a 25 white count and an 88% neutrophil. Same thing we've been doing. I'm going to take my white count, convert my neutrophil percent. What is it? Do I have a relative neutrophilia?
Yep.
Why? Greater than 80, out of normal range. What about, do I have an absolute neutrophilia? Uh-huh. So in this case, I have to go. I will put a couple more out there. And why do I care? Why do I care? Because you have to calculations of some sort to put on the test, I am. Why do I care?
Determine the leukocyte problem,
Yeah,
disease.
it's gonna help me narrow down, it's gonna help me figure out. If I don't have an absolute neutrophilia, I probably don't have myeloid leukemia. Okay. If I'm trying to figure out, do I have a lymph, and I can do the same, I can figure out my absolute lymphocyte counts as well. But truthfully, we don't care about that one near as much. We report the absolutes on every single patient. Because it's just calculation, the computer can do that without anything. It doesn't cost anything for it to report. But there are a lot of the chemo drugs that are out there, and this is becoming more and more common, that they're giving the drug and they're deciding how much to give based on the ANC. So we actually have them coming in going, they don't care about what the white count is. The pharmacist doesn't want to know what the differential is. They want to know one number and one number only. That's what they want to know. Yes?
So they use the ANC for antipsychotic medications as well.
I didn't know
A lot
that.
of our patients for schizophrenia.
Okay, that's good to know, thank you. But there are, and that's probably more what we're seeing than the leukemics then.
Yeah, we see a lot.
I was gonna say, that's probably, but we get a lot of pharmacies, especially on the weekends, never fails. But we get a lot of pharmacies calling for the ANC. We had to jump through a lot of hoops because our health information management people didn't want to send the records to the pharmacies. They said, we can't do that because it's not a physician. Well, so then what was happening is we're trying to send them to the physician who's then sending them to the pharmacy, and then meanwhile this patient's standing there wanting their medication, and so it's taking hours. So they finally did manage to get a certain group of pharmacies that do this a lot. They got them on board so that we can fax the results directly to them. But yeah, I didn't realize they were for the antipsychotics. Thank you, that was helpful. Yes?
Pharmacists can't prescribe certain things.
No, but they can calculate the dosage. The doctor will prescribe, X milligrams per times the ANC. Based on the ANC, the pharmacist, because the way pharmacy works most places now, you have to have a PharmD in a hospital. You have to have a registered pharmacist on site when you're dispensing medication. And one of the things the registered pharmacist can do is calculate dose. Just like you would calculate based on body weight, the pharmacist can calculate it based on the ANC.
So the pharmacist is just taking the dosage, the doctor's still prescribing the actual medication.
The doctor is prescribing the medication and the dosage, but he's prescribing the dosage as if the ANC is greater than this, if it's less than this, and I don't know the calculations, I'm not familiar enough with it, but basically if the ANC is this, then this is the dosage, or take the ANC times this and that's the dosage. So yeah, the pharmacist can calculate the dosage as long as the doctor writes the prescription that way.
But only if on the not master.
I don't know. I'm not familiar enough with that. I know our PharmDs can, but beyond that, I don't know. That's outside my field. But I know that this is a very important number to be able to calculate. Now, how do you think we calculate it at work? The computer spits it out. However, when they were first asking for this, the computer didn't spit it out. And so we're all over there, oh my God, when's the last time you calculated an ANC? Diane, oh, shut up. And the only reason I do it is because I torture you guys with it. It's not that I'm smart, I just have to do it. And a lot of people don't. So there's a lot of stuff I remember only because I torture you guys. Okay? It isn't that I'm bright, guys. Okay? I was bright, I wouldn't still be in school at the age of 50. So, is there anything else that I needed to go over? We talked about that, we talked about that. You guys did good on matching. Next week we will have, I think what I'm gonna do for the picture exams, rather than try and wait and add them to the paper, I'm just gonna give them their own test grade, because when I average it all up, it's all gonna go into the same pool, okay? So if you want to figure out, well, all you gotta do is add your test grade, add to your picture test, and then divide by the total number. And if you can't figure it out, let me know and I'll put that number on there for you. But it's easier for me if I can just put it in the grade book separately. But just so you know, it's all going to add into the same grade point. Okay, it's all at the end, takes all of the tests, adds all of the possible points, adds all of your points, divides it all out. It's all the same big mathematical pool. It's just easier for me if I can record them one at a time. And you'll love me more because you'll get your tests back more quickly. Okay, if you have to wait till I get the other one graded, it'll take longer. Because I'm off on Tuesday afternoons so that I can grade your tests. So I'm trying to get them done. This time, a lot of it wasn't grading it, a lot of it was deciding how I was going to assign the points. Okay. Any questions about what I will send out? There was more than one, so don't feel special. There was more than one of you who told me that the bleeding disorder was probably hemophilia because the protein was high. Is the protein elevated in hemophilia? The answer to that question is no. Only the PTT is elevated in hemophilia. And Jean did point out next year what I need to do is I need to add fibrinogen to that list to point to DIC more directly. Okay, so she's right. I should have put a fibrinogen level on there. Okay. Now, that was a bonus question, so if you didn't get it right, who cares? Okay, well I know you care because you want the points, but it doesn't really matter. But yeah, hemophilia, only the PTT is elevated because it's factor 8, 9, and 11, right? And those are only in the intrinsic pathway. You can't forget everything you already learned, guys. I know you're trying. I know the nightmares are still coming, but you can't let it go. Otherwise, when it's time to study for